Although the anatomy of the pelvic region has been known for many years, the function of the short arc muscles within the lower pelvis, the pelvic rotator cuff, has not been previously well delineated. Sagittal plane motions of the pelvis have been studied extensively, but transverse plane motions of the hips and pelvis, which are controlled by the pelvic rotator cuff, have not been analyzed in depth. Much like the short arc muscles of the shoulder rotator cuff, the short arc pelvic muscles work together synergistically to accomplish several tasks simultaneously. This series of pelvic muscles is essential for standing, walking, dynamic stability of the back, and bladder and bowel health. Understanding the form and function of the pelvic rotator cuff is a major key to diagnosing and treating pelvic musculoskeletal and urogenital dysfunction. The purpose of this presentation is to describe the muscles and function of the pelvic rotator cuff, its role in back and sacroiliac function, in standing balance and walking, and its control of bladder and bowel function. The pelvic rotator cuff is composed of a series of muscles, ligaments, and fascia contained within the lower pelvis and finds its support and many of its major attachments on the bony pelvis. The muscles of the pelvic rotator cuff include the obturator internus, superior and inferior gemelli, pelvic diaphragm, urogenital diaphragm, external sphincters, and adductors. The obturator internus runs from the greater trochanter of the femur, around the lesser sciatic notch, and attaches on the lateral aspect of the arcuate tendon and the internal perimeter of the obturator foramen. The arcuate tendon attaches anteriorly on the pubic bone and posteriorly to the ischial spine. The pelvic diaphragm muscles attach to the medial aspect of the arcuate tendon and to the pubic bone and sacrum. This allows the interaction between the obturator internus muscles and the pelvic and urogenital diaphragm and external sphincter muscles. The pelvic diaphragm interdigitates with the external anal sphincter. The external anal sphincter interdigitates with the urogenital diaphragm muscles at the perineal body. The adductor longus and brevis muscles attach to the pubic bone and shaft of the femur. The muscles of the pelvic rotator cuff work together as a unit during upright activities. Though we are all born with the basic structural elements of the pelvic rotator cuff, it takes the first 2 to 3 years of life for the PRC to develop in tone and function. The infant spends most of the time on his back, moving arms and legs into flexion and extension patterns. Improved muscle resting tone facilitates movement of the head upright, in prone and supported sitting postures. The trunk becomes more stable in sitting simultaneously with general tone increases. This in turn facilitates the beginnings of hip stability in sitting and all fours. In all fours, both shoulder and pelvic rotator cuff muscles gain strength and function through weight shifts. The abdominal muscles activate against gravity to stabilize the trunk between the shoulders and hips. Over and over, with each series of weight shifts, the rotator cuff muscles reflexively contract and inhibit to maintain balance over the 4-point base of support. Gradually, weight shift leads to unweighting of opposite arm and leg for forward progression in crawling. The pelvic rotator cuff action facilitates mid-range pelvic and hip rotation and lumbosacral stability during crawling. The child next arises to half kneel. During half kneel, the child isolates one leg in hip extension while the other hip is flexed. Weight shifts in this position develop the PRC in preparation for walking when the hips are acting in opposite flexion-extension patterns. When movement and stability over half-knee base of support becomes easy, the child pulls to standing. The standing position increases the demand on the pelvic rotator cuff in order to maintain balance with mid-range rotation through the pelvis and extended hip. In supported standing, the child bounces up and down, repeating the cycle of external and internal mid-range rotation, strengthening the PRC muscles. Initially, the standing base of support is wide in hip abduction and outward rotation. Later, the child cruises, that is, walks sideways around furniture. The first phase of forward walking is over a wide base of support, with arms, legs, and trunk working as one unit. Gradually, the base narrows as the hips adduct and internally rotate. Over a 6 to 12 month period of practice, the pelvic rotator cuff integrates abduction external rotation with adduction internal rotation, and the base of support narrows while hands lower from the guarded position. A 2-year-old's reciprocal arm swing and forward motion of alternate legs becomes separated from trunk motion. During this phase, the pelvic rotator cuff is key in developing dynamic stability throughout the pelvis, hips, knees, and ankle. At the same time, the child practices reciprocal hip-leg motions in other daily activities, such as climbing on furniture or toys. Sophisticated upright walking develops simultaneously with bladder and bowel control in the first 2 to 3 years of life. Stimulation from the autonomic nervous system and peripheral motor pathways influence resting tone of the pelvic rotator cuff and smooth muscle of the bladder and bowel. As the child progresses from digesting mother's milk to processing fruits, vegetables, and meats, nervous system directs the bowel, bladder, and rotator cuff in a progressively more sophisticated manner. From birth to 2 to 3 years of age, elimination is controlled primarily by the pons of the subcortex. Upon receiving the afferent message of bladder stretching, an efferent message is sent to the pelvic muscles, which release and eliminate the urine or feces without concern for time and place. Between 3 and 4 years of age, cortical inhibitory control of elimination becomes successful and the child can wait to get to the toilet. Thus, in the span of 3 to 4 years, the child progresses from supine kicking and lack of bladder and bowel control to walking and independent toileting. A major component of that progression is the improved sophistication of pelvic rotator cuff function. The lumbo-pelvic hip complex functions as an integrated neuromusculoskeletal system and is essential for human upright function. It is the body's balance point, the central connection between the upper body and lower extremities. It is the fulcrum for transfer of movement and force between these body segments while simultaneously providing stability within a bipedal framework. Dynamic stability of the lumbo-pelvic region is important because of the need to repetitively transfer weight, movement, and force of the upper body through this region to the legs and feet, and vice versa. The pelvic rotator cuff facilitates lumbo-pelvic hip stability through motor control of sequential, synergistic multi-plane motion and mid-range multi-plane rocking around the sacroiliac balance point. Stability arises from both passive and active components. The passive osteoarticular components include the actual shape and cartilage of the sacroiliac and symphysis pubis joints and the passive ligamentous structures supporting the SI joints bilaterally, including the sacroiliac ligaments, sacrospinous ligaments, and sacrotuberous ligaments. The ligaments supporting the symphysis pubis joint are the superior, inferior, anterior, and posterior pubic ligaments. These ligaments are non-contractile tissue that stabilize the joints through passive length tension. A dynamic component is added when muscle and associated fascia interdigitate with ligament tissue. As the muscle contracts, force transfers through the ligament, affecting the joint structures to which the ligament is attached. This can be seen in the adductor longus fascial interdigitation with the anterior pubic ligament. As the adductors contract, they exert force on the symphysis pubis, resulting in joint approximation. As the ligamentous and osteoarticular structures form the passive elements of dynamic stability, the muscles of the pelvic rotator cuff form the active elements of dynamic stability. In contrast to medium and long arc muscles, such as the gluteals and hamstrings, which move the legs through large amplitude motion, the short arc muscles of the obturator internus, superior and inferior gemelli, are characterized by being of relatively short length, running obliquely from origin to insertion, and moving the limb through small, mid-range rotation motions. For the purpose of illustration, we have exaggerated the minute motions of the symphysis pubis and sacroiliac joints which we will be examining. Pelvic rotator cuff action during the obturator contraction phase causes the hips to roll out and appears to compress the sacroiliac joints while decompressing the symphysis pubis joint. The obturator phase also appears to facilitate nutation of the sacrum. The base of the sacrum moves anteriorly in relation to the pelvis, which tilts posteriorly. In addition, the obturator's connection to the pelvic diaphragm via the arcuate tendon causes the pelvic diaphragm to lift, closing off the outlets for bladder and bowel during obturator contraction. The adductor longus and brevis have fascial connections that cross over the symphysis pubis joint and blend with the anterior ligament. Bilateral action of the adductors during the adductor contraction phase appears to compress the symphysis pubis joint and decompress the sacroiliac joints. Pelvic rotator cuff action during the adductor phase appears to facilitate counternutation of the sacrum. The base of the sacrum moves posteriorly in relation to the pelvis, which tilts anteriorly. In summary, during the obturator phase of pelvic rotator cuff action, there is outward rotation of the femur, sacroiliac joint compression, symphysis pubis decompression, sacral nutation, and posterior pelvic tilt. These motions occur simultaneously and are inseparable in function. During the adductor phase of the pelvic rotator cuff action, there is inward rotation of the femur, sacroiliac joint decompression, symphysis pubis compression, sacral counternutation, and anterior pelvic tilt. The equal but opposite balancing act of the obturator and adductor phase creates a continuous rocking motion around the neutral balance point of the sacroiliac, symphysis pubis, and lumbosacral joints, and facilitate dorsal and ventral ligamentous support of the sacroiliac joints in the neutral, stable position during upright activities. The back, pelvis, and hip joints play an important role in the ability to stand upright and walk. The muscles of the pelvic rotator cuff are essential in dynamic stability and mid-range rotation within this complex of joints for normal walking and standing balance. The ability to stand and balance is an amazing accomplishment. Standing is the first test in the ability to walk. Quiet standing occurs when the upper body center of gravity aligns over the lower body center of gravity. In reality, quiet standing is slow, continual arcs of body weight shift over a stable 2-foot stance. The pelvic rotator cuff rhythmically oscillates the pelvis and femur through small degrees of reciprocal rotation. When the pelvis rotates clockwise, the femur rotates counterclockwise. Then the pattern reverses. Through the action of alternating mid-range pelvic and femur rotation, the pelvic rotator cuff provides essential stability and force transfer from the upper body through the pelvic hip connector to the lower body. This postural sway is movement of the pelvis around the ankles via the hip joints and femurs. Because of the ball and socket shape of the joints of the pelvis and hip, this postural sway has a significant rotational component. Since rotation is an integral part of postural sway, the PRC, with its short arc rotation motions, is essential in maintaining standing balance over the foot base of support in a sinusoidal figure-of-8 pattern. The human body is built to move forward. Forward movement depends on continually losing one's balance and catching it. The stance leg performs constantly opposing adjustments with the pelvis to allow the swing leg to move forward through space and the upper body to remain over a base of support while achieving efficient forward movement. Dynamic instability occurs throughout gait. The midpoint of walking is the only momentarily stable time when both feet are on the ground. Otherwise, movement transfers from behind to ahead of the supporting 1-foot stance in a continual rolling motion with pivots at the heel and forefoot. Walking is rotation in a transverse plane through the pelvis, hip, knee, ankle, and foot. Mid-range rotation occurs in the pelvis and femur around the hip in clockwise and counterclockwise movements. The pelvis and femur always rotate in opposite directions at any given moment, and mid-range rotation occurs at the ankle and foot. At heel strike of the right foot, the pelvis is forward in counterclockwise horizontal rotation and posterior tilt in relation to the stance leg, while the femur moves in an external clockwise rotation toward mid-stance. From mid-stance to push-off, weight is transferred from the lateral border of the foot towards the metatarsal heads and the big toe by internal counterclockwise rotation of the leg. At the same time, the pelvis rotates clockwise to bring the weight over the big toe in preparation for push-off. Upon push-off, the pelvis rotates counterclockwise to propel the body forward. In combination with the stance leg, horizontal rotation provides efficient forward progression of the swing leg. At toe push-off, as the right swing leg is rotating clockwise, the pelvis rotates counterclockwise. From mid-swing to heel strike, the femur shifts to internal counterclockwise rotation, and the pelvis rotates in a clockwise fashion. Upon heel strike, the femur again shifts to external, clockwise rotation, and the cycle begins anew. The femur rotation is transferred to the foot as well, which pivots twice throughout the walk cycle in a sinusoidal curve. At right heel strike, a clockwise pivot occurs to transfer weight from the heel along the lateral border of the foot to the midfoot. Between weight acceptance and toe-off, the right foot pivots counterclockwise as it transfers the body weight forward and medially toward the metatarsal heads and big toe. After toe-off, the right foot pivots clockwise as it pushes off through the big toe to swing phase. The pelvic rotator cuff is the primary muscle system controlling the opposing mid-range rotations between the pelvis and femur during walking. This rotation in the transverse plane improves the efficiency and effectiveness of movements in the coronal and sagittal planes during ambulation. The increased efficiency is also due to the fact that rotation in the transverse plane lengthens the swing limb for increased step length, narrows the base of support in the distance between the hips, minimizes vertical rise during push-off, and minimizes lateral shift while facilitating load acceptance over the stance leg. Since pelvic and hip rotation direct ankle and foot pivots as weight is transferred from heel to toe, any limitation or dysfunction in the pelvic rotator cuff changes the walking pattern. There are many walking pattern deviations that occur to compensate when there is pelvic rotator cuff dysfunction. The shuffle walk and bounce step are two such deviations. The shuffle walk is often seen in the elderly. There is a lack of adequate mid-range rotation in the pelvis. The pelvis remains relatively rigid, which decreases step length. The lack of pelvic rotation leads to extremely reduced foot pivots and force transfer from heel to big toe. Without PRC control, walking is inefficient and the risk of falling is significant. Bladder and bowel control is lost at the same time due to dysfunction in the pelvic muscle support of the internal organs. The bounce step is seen in the younger population when there is dysfunction in the pelvic rotator cuff. To compensate for the lack of pelvic rotation and improper foot pivot, there is increased vertical rise during each step. The bounce is the fast transfer of force to the forefoot with little time taken for the heel pivot during stance phase. The step length is shorter and the vertical rise greater. Dysfunction in the pelvic rotator cuff during standing and walking leads to poor balance, increased incidence of falls, and walking deviations that increase energy expenditure and stress on all lower extremity and pelvic joint structures. If these gait deviations are observed, pelvic rotator cuff assessment and treatment is advised. As previously mentioned, bowel and bladder control becomes possible shortly after walking develops in children. This is no coincidence, as it is the pelvic rotator cuff that helps drive both functions. The pelvis is the scaffolding for the organs and muscles involved in continence. The bladder and bowel are supported by the pelvic diaphragm. The pelvic diaphragm is attached to the pubic bone and sacrum. It also attaches to the arcuate tendon, or white line, as seen here. The arcuate tendon runs from the pubic bone to the ischial spine on either side and interdigitates with the obturator internus muscle. The obturator internus connects the pelvic diaphragm to the femur by making a 120-degree turn at the lesser sciatic notch and extending to the greater trochanter of the femur. The roll-out action of the femur is caused by contraction of the obturator internus. When it contracts, it pulls on the arcuate tendon, which lifts the pelvic diaphragm, closing off the outlets for bladder and bowel control. The roll-in motion of the femur is due to contraction of the adductor muscles. When the adductors contract, electrical impulses travel up the muscle and transfer energy to the pelvic diaphragm, helping to maintain proper resting tone with the bladder and bowel outlets closed. While in early childhood the pelvic rotator cuff muscles strengthen to develop optimal dynamic back stability, proper walking, and bladder and bowel function, as a person ages, the pelvic rotator cuff and other support structures of the internal organs change in structure and function. The tissues thin, decrease in collagen content, increase in filler tissue, and decrease in contractile fibers. In a healthy 25-year-old woman, the pelvic diaphragm can be compared to 5 sheets of tissue paper. In a 65-year-old woman, it is more comparable to 1 to 2 sheets of tissue paper that are crumpled and have holes poked through them. The tissue in a 25-year-old is pinkish in color with muscle cells interspersed with connective tissue cells. By 65 years of age, there is more connective tissue and fewer muscle cells, resulting in a lighter pink to whitish appearance of the pelvic diaphragm. Hypoestrogenation after menopause leads to decreased blood supply to the pelvic muscles, decreased speed of nerve transmission, and decreased muscle contractile strength. Hypoestrogenation also leads to decreased collagen content, which is the main supportive protein in muscle and connective tissue. The collagen becomes meshed in form and less is newly synthesized. Thus, it becomes less mobile, is slower to respond to stretch, and tensile support is compromised. With age, thinning and descent of the pelvic diaphragm and fascial supportive structures cause a general descent of the bladder, bowel, and uterus. Because the pelvic diaphragm connects with the sacrum, this descended position can affect sacroiliac and lumbosacral joint position and function, and can be a factor in back pain, hip and leg pain, and foot dysfunctions. These physiological changes in the pelvic rotator cuff affect standing balance and can be a factor in falls and walking efficiently. Changes in the pelvic rotator cuff can lead to a loss of bladder and bowel control. With the move towards evidence-based practice, assessment of the pelvic rotator cuff dysfunction should include pre- and post measures in posture analysis, balance testing, gait analysis, and EMG testing. Additionally, pre- and post measures of hip, sacroiliac, and symphysis pubis function are included in assessment of the pelvic rotator cuff. Functional tests are best in light of the fact that motor control and balance seem to be the deficits rather than strength. Treatment includes re-educating the pelvic rotator cuff and rebalancing the nervous system. Since motor control and balance, not strength, seem to be the most effective targets of intervention, submaximal contractions of the pelvic rotator cuff in mid-range hip rotation and foot pivots is most effective. Autonomic nervous system effects on motor control alters response time and movement. Rebalancing the sympathetic-parasympathetic drive to the pelvic rotator cuff improves functional outcomes in low back function, standing and walking, and bladder and bowel control. One method of treatment is the realigning of organs and tissues through inversion roll for control exercises on a wedge. This can relieve symptoms when descent of tissues produces joint malalignment, nerve tractioning, and bowel and bladder descent. It allows exercise to be performed with optimal length of the muscle system. Without healthy pelvic rotator cuff control, standing balance, walking, bladder and bowel function, and lower back health all may suffer. Through an understanding of pelvic rotator cuff function and the ability to recognize signs of PRC dysfunction, the clinician can properly treat the patient without need for surgery or medication. Through a regimen of pelvic rotator cuff exercises, many symptoms can be relieved if not entirely eliminated.
Anterior cruciate tears and patellofemoral pain syndrome are the most common complaints and serious injuries to the knee in athletes and active individuals. Improving strength and function of the muscles surrounding the knee has been the primary therapeutic intervention. The influence of the hip muscles on knee function has been documented during rehabilitation of cruciate and patellofemoral injuries. Hip muscles located deep in the pelvis direct rotation within the knee joint during walking and upright functional activities. These muscles are especially important during sports like soccer and basketball. Deep hip muscle control of knee joint rotation is essential for healthy lower extremity function without injury. At the knee, the femoral condyles articulate with the tibial plateau and meniscus. The knee capsule encloses the tibiofemoral joints and the patellofemoral joint. The knee capsule is reinforced by ligaments, fascia, and muscles. The patella reinforces the anterior capsule. It is attached to the tibia by the strong patellar ligament and is connected to the femur via the quadriceps muscles. The hamstrings reinforce the posterior knee capsule with their attachments on the proximal tibia and fibula. The lateral capsule is reinforced by the iliotibial band and semimembranosus. The medial capsule is reinforced by the sartorius, gracilis, and semitendinosus. Within the knee capsule, the anterior and posterior cruciates reinforce central rotational movement and anterior-posterior shear. The anterior cruciate ligament runs from the intercondylar area of the tibia in an oblique direction posterior to the medial aspect of the lateral femoral condyle. The posterior cruciate runs in a vertical direction from the posterior intercondylar area of the tibia to the media condyle of the femur. The anterior cruciate ligament limits external rotation of the femur on the tibia when the foot is planted. It simultaneously limits posterior shear on the femur on the tibia when the foot is planted. It limits full knee hyperextension and extremes of valgus and varus. The posterior cruciate ligament limits inward rotation of the femur on the tibia when the foot is planted. It simultaneously limits anterior shear of the femur on the tibia when the foot is planted. It limits extremes of valgus and varus. Gluteals, hamstrings, popliteus, quadriceps. Stability and control at the knee requires interaction of forces produced by muscles and ligaments around the knee and hip. Interaction is especially important for movement control in the horizontal and frontal planes. The gluteal muscles attach around the hip joint and outwardly rotate the hip through its full range of motion. They secondarily affect knee rotation since it's a midline motion and more posteriorly based. The hamstring and popliteus muscles are the primary muscles running across the knee joint posteriorly and that affect its rotation. The hamstrings function to flex the knee and secondarily rotate the femur on the tibia. The popliteus is an important internal rotator and flexor of the knee. It unlocks the knee during standing when the knee goes from extension to a flexed position. The quadriceps attach proximately on the femur and distally to the patella and function to extend the knee. During knee extension with the foot planted, the patella is stabilized on the tibia by the patellar tendon as the femur extends and rotates in relation to the patella. The adductors, sartorius, and gracilis inwardly rotate and adduct the hip from full outward rotation to midline. Secondarily, they direct rotation action at the knee. An important and deeper layer of hip-pelvic musculature directs tension through the cruciates that creates knee rotation and dynamic stability at the knee. When in functional balance, this muscle system alternates anterior and posterior cruciate tension during upright activities. This group of muscles is called the pelvic rotator cuff. The muscles in the pelvic rotator cuff system include the obturator internus, obturator externus, superior and inferior gemelli, quadratus femoris, adductor brevis, pelvic and urogenital diaphragms, and external sphincters. The short hip external rotator muscles are ideally designed to produce an effective mid-range external rotation torque at the hip and knee. The adductor muscles, especially the adductor brevis, produce mid-range internal rotation at the hip and knee. The pelvic rotator cuff dynamically rotates and stabilizes the hip while spinning the femur and knee through alternating mid-range internal and external rotation during every weight-bearing step. Force transfer down the femur creates midline rotation action at the knee around the cruciate tethers. This alternating midline rotation is essential for knee stability and force transfer between the hip, knee, and ankle. Anterior cruciate injury occurs with extreme external rotation and posterior translation of the femur on the tibia with the foot planted. In conjunction with a valgus force, the anterior cruciate is even more inclined to tear. In many cases, it is a combination of factors that leads to internal tibial rotation torque at high velocity while the ligament is under tension. Frequently, anterior cruciate tears when the foot is planted and the athlete is cutting and turning to an opposite side. This is a sudden and uncompensated shear in rotational force at the knee without an effective counteraction in all three scenarios. A strong and balanced pelvic rotator cuff muscle system is designed to maintain the knee in rotational balance and prevent cruciate injury. Imbalanced mid-range outward and inward hip rotation changes knee rotation and patellar tracking. Patellofemoral pain syndrome is typically described during weight-bearing activities that use hip musculature to control knee motion. Previously, it was thought that the patella was laterally tracking improperly on the femur, but the latest research shows that femur rotation may be the primary consideration. This midline rotation deviation of the femur can occur when there is weakness or imbalanced action of the deep rotators of the pelvic rotator cuff. Significant weakness of hip lateral rotators and excessive internal rotation and adduction at the hip are significant in women with patellofemoral pain syndrome. Midline, mid-range hip rotation exercises can rebalance the dynamic knee spin to align patellofemoral function and normalize torque transfer through the anterior-posterior cruciate ligaments during walking, running, jumping, and pivoting. This is deep dynamic postural muscle work at the hip having to do with rotation in weight-bearing. Balanced midline, mid-range pivots in weight-bearing is the key to healthy knee function. The therapeutic progression begins in supine, progressing to sitting and standing.